Good morning and welcome to the Windsor-Essex County Health Unit's media briefing for Wednesday, January the 5th. Today we're going to move directly into media questions, which will be answered by CEO Nicole Dupuis and Dr. Shankar Nasathuri. Thank you very much. We'll take our first question from AM 800.
Nicole, just with children shifting to online learning starting today, do we have an update on our vaccination rates for children?
Yeah, just give me 1 minute. It should be updated on our website as well. And right now, I don't have the specific just 5 to 11 number, but our total population in the community, 5+ that are fully vaccinated, is 81%. But if you give me a second, I can confirm the number for 5 to 11.
Okay, yeah, I'll wait till the next round of questions. That's it for now for me.
Okay, thank you. Any questions from CTV?
Yes, good morning. With the instructions for residents about doing their own contact tracing, how are people supposed to be sure that they have COVID, maybe if they don't have access to rapid tests? And how do you expect them to, or do you expect them to truthfully notify contacts?
Well, using clinical symptoms as a diagnosis of illness is not entirely unheard of in clinical medicine. You know, when people have the flu, we don't test everyone who has the flu. We make that decision during flu season based on their symptom presentation. So the province's direction is based on the fact that testing capacity at the current time is limited, and therefore people are going to have to make the diagnosis on their own, and then make a determination of who their close contacts are independently of the public health service, although we can provide some general guidance on the webpage. I think that most people will follow public health direction. Clearly, adherence when you have a self-monitoring system or a self-directed system, it would probably be lower than one that's formally supervised by the public health service. Nevertheless, the provincial direction at this point is to focus all of our energies on vaccination. And we've reassigned people and reassigned resources to focus on the vaccination effort to manage the pandemic.
Okay, thank you. And with the wastewater testing, how much weight does wastewater testing hold? And are you continuing to look at this as a way to kind of indicate that the cases are increasing or the burden of COVID is increasing in the community?
Well, we have to make a big shift at this point in time about how we assess the burden of illness. In the past, we used the number of cases that, or the number of people that tested positive in any given time period to evaluate the burden of COVID. Now that COVID testing has been more limited and the availability is not as robust as it was before, we have to use other metrics to make determinations about is the burden of illness, what the current burden of illness is, is that burden of illness going up or going down? Using wastewater testing is one inferential piece of data that we could use to evaluate the burden of illness. It's not the only metric that one could use, but it's one metric. I think other metrics that we'd have to consider include the number of people who are currently hospitalized with COVID, the number of people who are currently in intensive care unit with COVID, the number of people who are on a ventilator related to COVID, the number of people who died in any given time period because of COVID, as well as the absentee rate, the number of people missing school, the number of people missing work. We'll have to use other measures to evaluate the burden of illness. I would share with you, we do use other measures or other items to measure the burden of illness with other disease states. So with the flu, we don't test everyone who has the flu. That's a resource decision in part. We make inferences about the flu based on other surrogate measures or other data elements. And I think, at least in the near term with COVID, that's what's likely to happen. In my dialogue with provincial colleagues, I know they're concerned about this as well, and they are formulating an approach so that we can give a summary of the burden of illness on a regular basis. And I hope that that summary metric is available in the near future.
Thank you. Now, before the holidays, you were calling on the province for more restrictions, and now they are in place today. What do you think of the level of the modified step 2 of restrictions? Are they too harsh? Are they enough? Just want your take on that.
Well, I think our provincial colleagues have to weigh decisions made based on their understanding of burden of illness across the province, and so they've made these determinations. There are options in a suite of measures that one could propose. And I think at this point in time, now that they've been announced, we monitor the situation and see what the effect of these measures are, and when these measures need to be, we'd have to evaluate if these measures need to be continued, potentially to be increased, or at some point in time, hopefully withdrawn or modified.
Okay, thank you.
Any questions from CBC?
Yes, good morning. The province now handles case and contact management. You touched on this a bit, but what is We Choose main priorities now that you've been shifting away from that?
So, I mean, our team does continue to support case and contact management, but you're correct. So majority of case management is done by the province, because contact management, as we've stated before, there's no contact tracing for most cases. They're asked to, identify and form their own contacts. For us as a health unit, as it relates to case and contact investigation, we're focused, based on the provincial direction, our focus is on settings that are defined as highest risk. So that includes healthcare settings like hospitals, acute care, long-term care, retirement homes, congregate settings, so shelters, room, lodging homes, things like that. So that's where our case and contact investigation is focused now for our team. I will maybe just add as well, our team this week, we'll be revamping our website. So we're working feverishly through all of the changes, and we'll be making sure that guidance is updated. So for example, guidance for workplaces, daycare is certainly, we're reviewing everything as it relates to school. And so we'll be working on, communications resources and tools, over this week and certainly the coming weeks.
You also mentioned, and obviously we know testing is limited, and we know that case counts might not be the way to track the burden of disease, but looking here locally, how is the health unit now tracking the burden of disease? For example, if the health unit needed to go past the current provincial restrictions, if an order needed to be issued for our community specifically, how is WeChew handling the burden of disease level in locally here?
Well, we're, these announcements and this policy direction occurred last Friday, and we got additional information earlier this week. I think we are evaluating what the correct approach should be to manage the burden of illness. We do have an epidemiology team that can help provide us with that guidance. I'm hopeful that the province will provide a framework, a group of metrics that will ultimately form a summary measure of what the burden of illness is, so that we can formulate decisions. In the alternative, we will use metrics which I had sort of highlighted before, and put perhaps an assignment of weight on them. So that would include the number of people who are currently hospitalized, the number of people in the ICU, the number of people on the ventilator, the number of people who died, the number of the level of absenteeism in workplaces and schools, the wastewater data, and together with that, we can formulate some measure of the burden of illness in the community. So I think either way, when the province formulates its guidance, we can incorporate that. And if we have to add local indices which serve a local purpose, we could do that as well moving forward.
Okay, thank you.
Any questions from Blackburn?
Yes.
Yeah, if I could add just one final comment to that last question is, we recognize, and colleagues in the media, we recognize that for the past 2 years, we've used case counts as a burden of illness. And in medicine, many times we do use the number of people affected by a disease to tell us how severe or how significant that disease might be on the community. The number of people who have colon cancer, the number of people who died of leukemia, or the number of people who tested positive for HIV. But that's only for certain disease states. For other disease states, we don't really have an exact count. And so we have to use other ways of making inferences about the burden of disease. Secondly, one of the goals of the public health strategy is, and perhaps one of the burdens, has been that with COVID, hospital resources or resources for the sickest patients, which are the people who go to the hospital, have been constrained. And they've been constrained because people who need other treatment for other diseases in COVID can't get the treatment because patients with COVID and people who need COVID-related services are crowding out, are occupying beds, occupying outpatient slots, occupying radiology slots. So that's one burden of illness. The other thing to think about is that as we have an increasing number of cases, there are more people disqualified from work. And absenteeism rate in a factory is important because it means that products can't get to people who need them. Absenteeism or the lack of staff at a hospital could mean that we would have to curtail hospital services, including closing beds and reducing operating room services, among others. So I think that when we evaluate the burden of illness, there's a whole variety of ways that we can make a decision beyond case counts. Although, and I acknowledge this, and I think we all acknowledge this, not having case counts makes it harder to communicate what the burden of illness might be in the community. Ashley, I'm sorry for interrupting you.
Not at all. Thank you very much, Dr. Desathury. Adele, any questions from yourself?
Yes. I wanted to ask you about accountability with people contact tracing for themselves. There is still a bit of a stigma to this virus, if you've got it. We've kind of trained ourselves to avoid anyone who is sick. So given that stigma, how confident are you really that people will go out and call their friends, their family, their colleagues and say, I've got COVID and you might now too?
So I'll start because I think it's important for, everyone to realize it's always been a little bit of an honor system. So even though the health unit would complete contact tracing, that information always has to be provided by the case. So the individual who has COVID would need to work with our team and identify who their contacts are, the places they've been, et cetera. So, again, it's just, they won't be telling us. You're right, it's probably a little easier to tell an individual or at the health unit. Maybe it is, maybe it isn't, I'm not sure, versus actively, calling everybody and letting them know. But I think, we feel confident that people will inform their contacts and let them know. With the new restrictions, there certainly will be, or there should be, and there will be a lot less person-to-person interaction. So I would think that individuals' number of contacts would be pretty small at this point in time. I'm sure Dr. Desathury would want to add something, but I just wanted to, sort of note that it has always been a bit of a, it always is an honor system. It is up to the individual to inform the public health service, and now certainly up to the individual to inform their contacts directly.
Yeah, I guess the first thing I'd share is at this point in the pandemic, the provincial direction is to place more resources on vaccine distribution and administration, and to reallocate resources from case and contact management towards vaccine. making decisions about priorities has always been a goal of the health system, and it's always been a goal of public health service. And this is definitely a shift from the previous strategy to the new strategy, and operationally asking people to self-recognize or self-identify themselves as having COVID, and making the communication to their close contacts and asking their close contacts to self-isolate is a shift. And it's likely that a self-managed process is less robust than a professionally managed process. I think we all accept that. But I do think that the majority of people will try to follow the guidelines and follow the rules. And as Nicole had mentioned, there are a couple of things to just consider. One is there's the case, the person who actually has COVID, and then there are the contacts, which are the people who have been exposed, but up to this point do not have COVID, but may ultimately get COVID and are at a higher risk for getting COVID. In almost every disease state, be that syphilis or HIV, when we do case and contact management, we rely on the truthfulness of the person who's the case to help us do the contact management. That's not new. That's been the practice, and in fact, we anticipate the cooperation of the person who has the recognized illness. So I think at least the ethical obligation to community members has not changed. How it is effectuated and how it's monitored has changed, but the actual idea of being truthful has not changed in any substantive way.
Now, when we talk about the honor system, though, there can be penalties for not being fully honest with public health officials, as there would be, say, with HIV, if you had a sexual partner and did not tell them. And if I may be wrong, but I remember earlier in the pandemic that there was talk about some kind of penalty for people who did not cooperate with public health officials in listing their contacts, where they were, and giving public health relevant information to protect the public. Is that still the case?
I'm not a lawyer, so I don't want to give a legal opinion on this, but the statute provides the public health statutes provide a broad range of options for people who affirmatively do not want to comply or affirmatively do not want to adhere to public health guidance and direction. That being said, I'm always, as public health officials, are reluctant to use enforcement authority when the public health goal can be achieved through dialogue and trying to convince people to do the right thing. But reading the statute, as my understanding is, there still remains enforcement authority, and when appropriate, we would use the enforcement authority as provided by the public health law.
Okay. Was there anything out of today's EPI summary that stood out to you, like our positivity rates or anything like that?
So we don't have, are you talking about our weekly EPI summary? We are reporting that today. I will have that for tomorrow. The only question, maybe I'll answer Rob's question from earlier, just as it relates to our vaccination rate. So for 12 to 17-year-olds, it's 76.5% of our total population of 12 to 17-year-olds that are fully vaccinated. So that's 2 doses. And for those 5 to 11, right now for 1 dose, it's 33.7. I mean, we have seen a little bit of a plateau for both of those populations. So just answering that question, but to answer your question, Adele, we'll have more, I think, updates on trends tomorrow when we have our EPI summary.
Okay, thank you very much. I'll have more later.
Thank you. Any questions from the Windsor Star?
Yes, good morning. Given all you've said about case counts today, will the health unit continue to share daily case counts in the near future once they become a far less accurate metric of the burden of disease?
So this is something that we are, I think Dr. Nestori mentioned earlier on, that we are discussing internally. You know, what will we be able to share? Certainly right now, everyone would know that, you know, today, for example, we reported 353 cases. There is a delay in when we're receiving those results. So, and this change just happened. So over time, you know, over time, I think we'll still report what we can, and we're just talking about the frequency of that reporting. We want to ensure whatever we're reporting is meaningful, and that we can provide the right narrative, so that, you know, the public, the media, you know, will understand what, you know, what to take away from the numbers that we are reporting. So, you know, we are committed to reporting what we can. And if, as far as the daily versus, we have talked about whether it would be daily or if we move to weekly. And so those are things that we're just talking about right now. But for the moment, we're still reporting our numbers daily because they're still trickling in. And I don't know if you want to add anything, Dr. Nestori.
Yeah, you know, what I would share is that we will continue to share with the community and to our colleagues in the media our current assessment of the burden of illness based on the data that we have. I think that it'll be a bit more nuanced about what inferences we can make, because it'll likely be a suite of measures or a suite of metrics that ultimately will be formulated into one summary metric. But we continue to share that. We want to try to give data that accurately gives insights into the burden of illness, and we're working through that right now. So that is a priority, so that we can report in a meaningful way as we move forward.
You've mentioned several times, Doctor, absenteeism rates. Can you give us a sense of how the health unit monitors rates of absenteeism in workplaces?
You want to start, Nicole, and I can sort of supplement that, or?
Yeah, so for workplaces, we don't have a system per se for capturing that outside of, again, those workplaces, facilities that we're monitoring, that we monitor, so those higher risk settings. For schools, for example, you know, as a health unit, we do work with the school boards to report. They report their absenteeism, and we do monitor that. And we have, prior to COVID, and continued that certainly through COVID. So we do have a system in place for monitoring absenteeism within schools. You know, and that's certainly for us an indicator, or you know, an indicator of disease burden or illness within the community. So those systems are in place, but we don't have a broad system for, you know, workplaces reporting absenteeism.
So as we go through this, we'll have to formulate a practice or a strip approach to try to get data elements. So part of formulating a metric is not only deciding what data element would be helpful, but how one would get those data elements reported. You don't necessarily have to have 100% reporting to make inferences about burden of illness. Now, many of the largest employers, in fact, we have interactions with on a regular or semi-regular basis. So in many communities, the hospital and school board are some of the largest employers, and we have regular interactions with both of those institutions, and we can get data from them in that way. In Windsor-Essex, there are several large commercial employers, and they too probably have internal mechanisms to report absenteeism. So we'll have to formulate a plan to get insights into the metric of absenteeism. Why is the absence rate important? Because it is reasonable to infer that the more people missing work, the more that a percentage of those people missing work are likely missing work due to illness or being disqualified because they're a close contact. And as the absenteeism rate goes up, you would infer that the burden of illness goes up. And as the absenteeism rate goes down, one would infer that the number of people affected by COVID has reduced. So that's what we're working towards. There's always imperfection in every data element that's collected. Although case counts might seem like a perfect measure, in fact, they have imperfections as well, meaning that there are people who are sick with COVID who don't get a test. And so we don't really know about those individuals. Sometimes the test can be wrong. And, we have to make estimates or impute some variability in those case counts. So, in the end, we'll try to do the best that we can to evaluate the burden of illness within the resources that we have at the health district.
Thank you.
Any questions from Radio Canada?
No, thank you.
We do have time for one follow-up question per outlet. So starting with AM 800.
Nicole, just in regards to the vaccination rates for youth, where are we at on a province level? Are we lower than the provincial average, higher? And like you said, it kind of plateaued. So are you surprised by that?
I think, yeah, no, I'm not. I guess I wouldn't say I'm surprised. We knew, in particular, I think I had said with the 5 to 11s, we saw the same with the 12 to 17, where we saw, a quick increase at the beginning, and then, rates of vaccination tapering off a little bit. So, as well, with the holidays in there and the announcements for in the opening up for adults for third doses, although we have continued to prioritize first and second doses. I think, that certainly changes the landscape as well. Compared to the province, I think I'm pretty sure we are still below the provincial average. I haven't checked exactly where we are, so we can certainly send you that in an email as a report. But we still have work to do. We are continuing to have conversations with our school board colleagues, and those who work with children and youth, within our region, to see what we can do to reach out to parents, to provide more education, answer questions, and also, as we're redeploying all of our resources to vaccine, as you know, there's a lot of priorities right now. We've opened a mass vaccination site in Leamington, which opens officially today. There's the mass vaccination site in the West End at Hotel de Grace. As well, we're ramping up our mobile vaccination teams. So the hope is that certainly we'll be able to continue to get out into different pockets of the community, and we'll still support schools, certainly with school clinics and opportunities. Some of those have been quite successful. I know I mentioned before the few days we spent at John McGivney, we were grateful to have their support in that, and it was an incredible event. So those are things that we'll continue to do in the new year, and certainly hopefully our case numbers and what's happening in our community will be some increased incentive for people to get out and get their vaccination.
Thank you.
Follow-up question from CTV.
I know the increased restrictions are provincial direction, but what is your message to local residents who got vaccinated, thinking that there would be no more lockdowns or restrictions, and now they feel upset and don't want to follow public health guidance anymore?
Well, I think that getting vaccinated has benefits to the person who gets vaccinated, notwithstanding what else has happened in the province or in provincial policy. If you get vaccinated, you're less likely to get sick from COVID. If you do get sick, you're going to have less significant burden of illness, meaning that you're much less likely to be hospitalized, go on a ventilator, or die. So I applaud all those people who have got vaccinated, because they're helping themselves and they're helping their families, recognizing that a good number of the people who get exposed at their home from a sick person or a person infected with COVID. And if you're vaccinated, you're less likely to transmit that illness to other people, including your family. I recognize, and I think we all recognize, that it's going to be starting, it'll be in March 2020, so it'll be nearly 3 years, it'll be the third year of trying to manage the pandemic coming up. People are weary of the pandemic. They're weary of the restrictions that have been put forth. I think our best approach to control COVID is something that's still within our control. which is to get vaccinated. And we can give you what we estimate our latest numbers are, but the last time I reviewed the data, there are about 50,000 people in Windsor-Essex who are not vaccinated. And the unvaccinated people constitute 2/3 of the people who are currently dying from COVID. And we can ask for those numbers to be looked at again. But for the most part, the people being hospitalized with COVID are unvaccinated people. Of the vaccinated people that are dying of COVID, many have severe or significant concurrent medical comorbidity. So it's still within our power to try as a community to bring COVID under control. And those people who are eligible for the 3rd dose of the booster should get the 3rd dose. Those people who have not been vaccinated once or twice, they should get it. I appeal to them again, and we have the Public Health Service appeal to them again to get vaccinated. I know I repeat this message, but it's worth saying. If you can't get vaccinated because you don't want it for yourself, do it for your family and children. Do it for the other people that you might help. If you get vaccinated, you're less likely to go to the hospital. If you're less likely to go to the hospital, that means that people who need other health services can get treatment. Even if you can't do it as a long-term strategy, at least do it for this year, so at least we can get through the pandemic, or do our best to get through this period of the pandemic.
Okay, thank you.
I hope that answers your question.
A follow-up question from CBC.
Yes, thank you. Vaccination rates in the N9A area, which is mostly the Windsor's downtown core, the vaccination rates there are some of the lowest in Windsor-Essex, if not the lowest, and it continues to be a hotspot for COVID cases. Is the health unit considering prioritizing vaccination appointments based on postal codes, or putting in access to pop-up clinics in that area?
So we do continue, we do continue to have a mobile team. So we have our own health unit mobile team as well. We work with pharmacies and primary care, partners within the community to increase access as well. We are also partnered with the High Priority Communities Strategy, which is led by CMHA, supported by Erie Shores and Erie Shores Healthcare and EMS. And they have a large mobile team for vaccination, and the High Priority Communities Strategy is primarily focused on those areas that have had a high burden of disease from COVID, have N9A being one of the main postal codes, but it's those FSAs, those high priority FSAs that they are focused on. So we do work with them. We have continued to offer mobile vaccination opportunities within, the N9A area, as well as other postal code areas that are considered high priority and have lower vaccination rate. As well, we as a health unit have worked with school boards to offer clinics, and we prioritize schools that fall within the areas that have a lower rate, including N9A. We've done quite a few, and they've been quite successful. So we'll continue to do that. As I said earlier, we're also working with our school colleagues around education opportunities as well as clinics in some of those areas where we know, have a lower uptake of vaccination. And then I guess lastly, I'll just add individuals, so not specific to a certain postal code, but for those individuals who are still not fully vaccinated, so haven't, still need a first or second dose, they are still prioritized. So they are prioritized, within all our mass vaccination clinics, and so anyone who needs the first or second dose should be able to get that, right away. And so that priority will remain.
I think the issue too is to consider is that there are multiple channels of distribution of vaccine at the current time. There are pharmacies, physicians' offices, community vaccination centers or mass vaccination centers, mobile vaccination programs. The barrier to vaccination on a community level is not access to the vaccine. It's not the availability of the vaccine. It's individuals making a decision that they should get vaccinated. And that's where I think we should focus focus our energies at. It is true that some postal codes and some geographic areas may have people who live there who have lower vaccination rates, but always caveat to that is where people live is not necessarily where they spend most of their time. It's one inference, but not the only one. And so we recognize that these are opportunities to help improve vaccination rates, but also to think that for most people, the solution or on a population health level is not increasing vaccine availability as much as trying to convince people or encourage people to actually make the next step and get the appointment and get vaccinated.
Thank you. Any a follow-up question from Blackburn?
Dr. Nessathuri, I know you did your damnedest to try and keep schools open. And of course, today the kids have shifted to online learning. We have high absentee rates at our hospitals right now, over 220 at Windsor Regional alone, and Erie Shores is also reporting staffing difficulties. Where did we go wrong here? Is it just simply that this is so transmissible? Or is did the system fail us somewhat?
Well, the one thing about the pandemic we can be sure of is it's not predictable, and the closing schools was a province-wide decision and not a local health district decision. I think that at least from our perspective, the health district's position is that schools should be the priority, and and closing schools should be less emphasized in managing or trying to break the chain of transmission, because we believe, and I think many public health officials believe, that schools are such a vital component, especially elementary schools, for the well-being of young people. I think time will tell when there's an analysis at the end of the pandemic about what were the right approaches and what approaches perhaps were not as effective. And I think we'll have to wait for that analysis. I remain optimistic that after this 2-week period, the schools will reopen for in-person learning, and we should continue to emphasize that as a goal at the health district level and across the province.
Thank you very much.
Follow-up question from the Windsor Star.
No, thank you.
And a follow-up question from Radio Canada.
Yes, Nicole, you said that you are actually revamping your website. So I just want to know what is it about, and when can we see the new version online?
So I think, as you all know, guidance changed the, end of the day before a holiday weekend as well. Additional announcements, were just made. So, which, changes when we look at, who's prioritized for testing, the changes to case and contact management. It's a pretty large shift in how we were operating to how we will, move forward. So, we're revamping, we have pages for and directions for workplaces that'll need to be changed, schools, daycares, individuals. So our team met yesterday to review all the changes that need to be made, and we'll be working, it's our priority for this week. So our hope is to have everything up and running, and those changes, you'll start to see them pop up this week. So I'll give an example, our workplace page again, we already do have fairly good information on there around how to manage COVID in a workplace, but we'll just be certainly updating that as it relates to our role versus the role of the workplace versus the role of the individual. And any new guidance that has come out, we'll make sure that that continues to be up there, and we provide templates and resources and tools for workplaces to communicate with their workers. So those are just some examples of the changes that we'll be making.
Thank you.
All right, thank you for joining us, everybody. We will wrap up for today, and we will meet again tomorrow morning on Thursday, January the 6th. Have a wonderful day.
Thank you.
You too.
Thanks.
Bye-bye.
Bye.
Thank you.